Can everybody hear me? Yes? Can you hear me? We're good? Yes? Hear me? Okay. Good evening, everybody. For those of you that don't know me, my name is Suzanne Spurnall. I'm the Senior Vice President of the Women's Health Service Line. Thank you for being here today. I know a lot of you hit traffic and some other unexpected things, so I appreciate everybody making the time and the commitment to advancing the conversation around women's health and wellness. Unfortunately, Mark Manigan couldn't join us tonight, but I am excited to introduce someone just as dynamic to kick off our evening, our Chief of Staff, Indu Liu. Indu has been in her current role as Executive Vice President and Chief of Staff since 2022. Prior to the Chief of Staff role, Dr. Liu served as the Chief Pharmacy Officer at RWJBarnabas Health, where she had oversight and provided strategic leadership for the 27 divisions within the pharmacy enterprise. Indu was also responsible for coordinating and leading RWJBarnabas Health's COVID-19 vaccination strategies with over 500,000 vaccines administered. Right? That's a lot. Indu has served as the president for the New Jersey Society of Health System Pharmacy, and she is currently serving as a member of the Board of Trustees for Rutgers University and on the board of the Executive Women of New Jersey. Indu also serves on the National Advisory Council for the Dispensary of Hope. This is really just a snapshot of everything that Indu does, and if I stood up here and shared all of her accomplishments, we'd be here till tomorrow. So it is my pleasure to introduce my colleague and someone that I am privileged to call friend, Dr. Indu Liu.
All right, so I don't do well standing in one place, but I will try to stay in one spot. I'm sorry, Caitlin, for messing up your microphone situation here. Oh, see, this is much better. Okay, I got to take that off. Thank you, Suzanne, for that lovely introduction. As Suzanne mentioned, Mr. Manigan sends his regrets for not being able to be here with you tonight and share this wonderful event. For me, it is an honor to be with all of you. Thank you to our dedicated trustees. I met many of them here today. Thank you to our management leadership team and patients for joining us today for this incredible event. So often the perception of women's health is limited to just OBGYN care, but we all know it is so much more than that. That narrow perception misses the full scope of women's roles as consumers, leaders in their communities, and also decision makers for their families and friends. Later on, you'll see, and I got a sneak peek of it, I'm sorry, I'm not gonna spoil anything, but you will see videos of our patients, and these patients range from teens to seniors, and they cover the entire continuum of care when we're talking about women's health. Many times, women are at the center of their families and their communities and often shape the healthcare decision for their families and others. And this is why many times women are referred to as the chief medical officers of their homes. I want to recognize the incredible progress that Suzanne, under her leadership, and the Women's Health Service Line has done to advance the care for the entire state of New Jersey, for women in the entire state. And they do so in a very compassionate and equitable manner, which is really centered around our commitment statements and our credo. We are dedicated to making women's health a priority in this state and for our system. You can see that we're investing in infrastructure. This building is phenomenal. Every time I walk by here, even the reserved signs, can I see that, Susan? All right, even the reserves, look how it's not paper, it's so fancy. Even the reserve signs here are so fancy. But we're doing so tonight. We're here in this beautiful location, and we want to be the choice provider for women across the state of New Jersey. Our service line strategy is prioritizing partnerships like this event tonight to tailor to the unique needs of women. We lead the state in maternity care. We're increasing access to care for women of all ages. We're recruiting world-class providers like those joining us here tonight to care for women in all phases of their life. creating a network that is not only exceptional, but centered around kindness, compassion, and care for the holistic person. At RWJBarnabas Health, our mission is pretty simple. We are partnering with our communities to build and sustain a healthier New Jersey. And in order to realize that mission, we have to begin with certain tenets, our values of kindness, compassion, empathy, respect, and teamwork. The level of care and compassion demonstrate what we're doing, and we're pairing this with our talented providers within New Jersey to transform women's health across the state. RWJBarnabas Health and its generous donors have made a transformative investment in world-class facilities to ensure that women have access to care, comprehensive care, in their neighborhoods, close to their home and close to their family. You don't want to have to drive across a river, a bridge, take a bus, drive far to get the care that they need. And this support is not only the physical support that we're talking about, but we're also providing care that affects the social determinants of health. We provide homes to the homeless. We provide tens of thousands of meals to those that are hungry for food deserts. We provide diapers, transportation, thousands of rides via Uber Health to make sure that people have transportation to care. We've hired over 1,600 of our coworkers from Alice neighborhoods. And for those that may not know what an Alice neighborhood is, it's an asset-limited, income-constrained neighborhood. We not only hire local, but we buy local as well. We've invested over $42 million in minority-owned, women-owned, veteran-owned businesses, which is absolutely incredible, because what that does is it contributes to their financial health. And we know that's part of social determinants of health as well. And I know you've heard Mr. Manigan say this, but we are the state's largest provider of charity care and care to the beneficiaries of the Medicaid services by 2 times any other health system. This is part of our mission. And part of our mission is to provide the care to women, the highest, most exceptional, compassionate, equitable care to women across the state. So thank you everyone for being here tonight. I look forward to Molly Kroon for moderating this panel. And I'd like to thank our panelists. They are devoting their time, their expertise, their passion for the panel here today, really for the purposes of learning how we can connect women to these services. So definitely want to thank Drs. Chen, Garcia, Coley, Kulkarni, Murtha, and Wang. So thank you, and thank you very much for the opportunity here today.
Thank you, Indu. We are honored tonight to be able to share stories from some of our patients from across the system. Each story highlights the profound impact that dedicated providers and supportive networks have on the lives of women. You guys ready?
I started playing lacrosse when I was 8 years old. My senior year of high school, I tore my ACL. It was really upsetting. When I first arrived my freshman year at Rutgers, I began working with my RWJBarnabas health team, getting me back to a place where I felt confident in myself. My sophomore year, I was able to get back on the field, and I just turned the wrong way. As soon as I went down, I knew that my ACL was torn. It was an awful feeling. I did know that with the people that I had by my side that I could do it. As a woman, I feel like they gave me all the confidence and strength and respect that I needed to get through this injury.
Victoria Goldrick, player that missed the first 2 seasons due to injury, come back with a vengeance.
I'm doing amazing now. I never thought that I would be back on the field starting. I just want to say thank you to my RWJBarnabas health team. Now I want to do physical therapy, and they made such a big impact on me that they pushed me to want to help people like they do.
Me and my husband decided we wanted to have another baby. I got pregnant 3 times and miscarried all 3 pregnancies. I went to get genetic testing. They said I had lupus and a clotting disorder. I got pregnant again, and I didn't have any hope. Then I came to RWJBarnabas Health. I got linked up with a rheumatologist and a hematologist and my high-risk OBG, and he said, forget everything that happened before, this is gonna be different. It was amazing. It took so much stress and worry from me. They just managed everything. When I had my baby, I forgot about all the heartaches, all the hopelessness. I felt the room filled with love. My OB, he had the biggest smile in his face. He held her like it was his child, and he was like, we've been waiting a long time for you, all of us. I'm very blessed. If it wasn't for RWJBarnabas Health, I don't think I'd be able to have the family that we have today.
I was about 16 years old when I started developing disordered eating. I suffered for over 20 years. I was near organ failure. I don't even know how I was taking care of a baby as well as 2 other children. My family members were researching the best place for me, and they chose RWJBarnabas Health. They understood who I was as a person, and I think that's what sets them apart from other places. If I hadn't sought help here, I was pretty much near death. I recently published a book which talks about my time here and how, because I was able to address the traumas in my past, I was able to not only heal from them, but to find the beauty in them. RWJBarnabas Health, they didn't just save my life, they gave me the opportunity to start a new one.
When I was 40 years old, I was feeling extreme fatigue. Fortunately for me, I came to RWJBarnabas Health, met this wonderful cardiologist who looked into the problem that confirmed that I needed monitoring. I used to come for periodic checkups. 18 years later, I again felt very exhausted.
I knew that RWJBarnabas Health will give answers.
Given all the testing, best course of action would be to have an implant of a pacemaker along with a defibrillator.
RWJBarnabas Health
Particularly seems to care about women, making sure that they address the way the symptoms arise at different stages of life. Not a day goes by without my feeling very blessed and thankful to RWJBarnabas Health for allowing me this wonderful lease on life.
Let's be strong together.
Let's be joyful together.
Let's be inspired together.
Let's be healthy together.
I have seen that video like 30 times, and every time I watch it, I'm like, wow. It's just wow, right? It's unbelievable. And there's nothing more powerful than patient stories. Like, we could go home tonight with a clear message, right? Without the panel discussion, without anything. That video says it all. And we have some of our grateful patients in the audience, and we're so thankful for their willingness to share their journeys with us tonight. So can we give them a round of applause? And now I would like to introduce to you our panelists who will join us on stage as I introduce them. Dr. Serena Chen. Dr. Chen holds many titles. She is the Division Director Emeritus for Reproductive Medicine at Cooper-Barnabas Medical Center. She is the Director of the Advocacy Institute for Reproductive Medicine and Science for CCRM, and is also the co-founder of Doctors for Fertility. Dr. Chen is passionate about access to treatment for infertility and fertility preservation for all. She is proud, honored, and privileged to have played a role in obtaining better access to IVF and egg freezing for the people of New Jersey. She won the Resolve Hope Award for Advocacy in 2020 for this work. Please welcome Dr. Serena Chen. Next is Dr. Sue Wang. Dr. Wang is the medical director of both the Center for Asian Health and the Viral Hepatitis Programs at RWJBarnabas Medical Center. Dr. Wang is an internist and runs a program that serves the growing Asian population in New Jersey, many of whom encounter barriers to accessing healthcare. She is also a global advocate for people living with viral hepatitis, with a special focus on pregnant women and children. Please welcome Dr. Wang. Our next panelist is Dr. Rushana Kulkarni. Dr. Kulkarni is the Director of Community Cardiology and Preventative Health for our Southern region, as well as a physician leader for the RWJBarnabas Health Women's Heart Health Collaborative, great partner to me on that initiative. And Dr. Kulkarni is the past president of the American Heart Association of New Jersey. She has served as the chief of cardiology and the chairman of the Department of Medicine at Robert Wood Johnson University Hospital in Somerset. And her areas of interest are preventative cardiology and heart disease in women. She has dedicated her time and efforts to raising awareness for heart disease in women and has presented both nationally and internationally to further that cause. She was also awarded Physician of the Year by the American Heart Association. Please welcome Dr. Kulkarni. Next is Dr. Manpreet Kohli. Dr. Kohli is the director of the Division of Breast Surgery at Monmouth Medical Center and a physician liaison for the Commission on Cancer. As an associate professor with the General Surgery Program, she is very involved with resident and medical student education. Dr. Kohli is also involved with the American Society of Breast Surgeons and other industry leaders in lymphedema prevention. Many of you are probably not aware that Dr. Kohli gave a brilliant TEDx performance last spring titled When You Should Be Screened for Breast Cancer. It was absolutely outstanding. And she is the founder of I Pink I Can. Please welcome Dr. Manpreet Kohli. Our next panelist is Dr. Amy Murtha, Dean of Rutgers Robert Wood Johnson Medical School. Dean Murtha is an OBGYN specializing in maternal fetal medicine. She joined Rutgers 2 years ago from University California, San Francisco, where she was the chairperson of OBGYN, which is one of the largest obstetric departments in the country. Prior to her time at UCSF, she served as a professor in the Department of OBGYN and vice chair for research in OBGYN at Duke University. She established and led the Duke Clinical and Translational Science Institute's clinical research unit and raised the department NIH funding ranking from 57 to 17. Dean Murtha is deeply committed to supporting the health of women before, during, and after pregnancy and throughout their entire life. Please welcome Dean Murtha. When she and I were talking last night, she said to make sure that you tell everybody that I'm nice and I'm funny. And our final panelist is Dr. Johanny Garcia. Dr. Garcia currently serves as Vice President of the system's Population Health Team. In this role, she leads clinical programs across the health system and the continuum of care to ensure the delivery of high-quality, empathetic, equitable, and efficient care that improves the health and wellness of our communities in New Jersey. Dr. Garcia is also an assistant clinical professor of medicine at the Rutgers, New Jersey Medical School and loves teaching residents and students. Dr. Garcia's greater than 20 years experience as a physician leader and provider includes serving 5 years as the Deputy Associate Chief of Staff for the Veterans Health Administration in New Jersey. Please welcome Dr. Garcia. And finally, I am pleased to introduce and hand over this microphone to Molly Kroon, video producer, former on-air TV reporter, and tonight's panel facilitator, who will lead the discussion. Please welcome Molly Kroon.
Well, this is a real honor for me to be on this panel with such highly esteemed physicians to talk about a topic that is just so important to women, to families, to communities, and to this nation. So I really look forward to this. Thank you so much for participating. I'd like to start with Dean Murtha. Suzanne shared with me a statistic that I found pretty shocking, actually, that according to the American College of Obstetrics and Gynecology, by 2050, we could see a deficit of nearly 22,000 OBGYNs in this country. 22,000. And it's clear that the need for women's reproductive health services, that's not going anywhere, right? So here at RWJBarnabas, the health system is so uniquely positioned to really help bridge that gap with this incredible academic partnership with Rutgers. And I'd like to talk to you about what strategies you think that can be implemented to attract more physicians into this incredibly important field.
So thank you for the question. Can you guys hear me?
Yes.
Awesome. So first, actually, I just want to say thank you for the opportunity to be here on this panel. It really is my honor and privilege, and I'm now about 2 years in, and I've been at some pretty prestigious organizations, but never been at a place that really values women's health the way this organization does. So incredibly grateful to be part of this enterprise and to be partnering with the health system, especially in the women's health space. Of course, I have to be agnostic in my other roles to all the other specialties. The question about building the workforce for women's health care. And we'll talk about physicians just for a second, but I think we need to think more broadly about how we provide women's health care, because it can't just be filled by physicians. So OBGYN residency programs across the country, as many of you know, medical students apply to programs, they interview, and they match. There were 3 open spots across the United States in OBGYN residency programs. There's not a shortage of interest. It's an incredibly competitive field to get into. People want to be OBGYNs. We don't have enough OBGYN residency spots. That means that if there were only 3 open spots, and Archana could probably tell me, it's probably like 1,000 plus spots in the country, and only 3 were open, that means that many students interested in doing OBGYN did not actually find a spot to do their training. It was actually well north, I think it was like 200 or so that didn't match. So there's a significant interest and a paucity of GME, or graduate medical education training locations. So around the country and in New Jersey, we need to increase the number of high quality graduate medical education residency training slots. That is one thing that we need to do to be able to address the workforce issue. In my opinion, it's not the only thing though, because there are other care providers that can help to provide high quality women's health care beyond just physicians. So nurse practitioners, nurse midwives can certainly support the workforce to be able to provide that high level of care. And that's a space that I think we also need to focus on. And I would say uniquely partnered with Rutgers means that we are also partnered with the School of Health Professions and the School of Nursing, where those programs exist, and provide an opportunity to help build that workforce, especially for New Jersey. I'll just say one last thing. The other thing that's really important across the United States is that we identify where we need providers to practice. There are population-dense areas where there's high numbers of physicians, not just OBGYNs, but physicians in general, but certainly for OBGYNs as well. And there are places in the country where hospitals are closing their labor and delivery units because it doesn't make sense for them to provide obstetric care. Those places we have to do something different for, because women have no choice. There are those locations in our own state. where hospitals are shutting down their labor and delivery units and women have to travel long distances to be able to deliver their babies. So that's the other priority that we need to focus on as well. It's not just a workforce, but it's actually making sure that we're providing the right care in the right place at the right time.
Well, this topic of access. Women make 80% of families' healthcare decisions, right? The chief of staff of families, the CFO, CEO. So when we promote healthcare for women, we really are promoting the health of the community and the nation as a whole. So how do we ensure that women do have that access to comprehensive health care, and also for families and women in socioeconomic status, regardless of their status? How do we provide that access? And I'd like to start with Dr. Garcia, actually, for that.
So thank you for that question. I think it dovetails very nicely with workforce. When I think of women, and in my career, the stories that come to mind, as we saw in the video, are stories of women coming to care really with their families. Women are the CMOs of their families. They're making the decisions, the healthcare decisions for their families. And therefore, we need to tailor a healthcare system that works for women. Women who work, women who lead families, women who are caretakers, and women who do not take care of themselves. And so when I think of those populations of patients, and we're all trained to see patients one-on-one, and for me in my role in population health in the system, I have an opportunity to look beyond that. How can we help not just one person or two, but how can we help a whole special population of patients like women? And one way to improve access is really to break down the silos between care that's only focused on reproductive care, which is very important, maternal care, but also care for chronic illness, care for mental health. Women are all those things. And I think that's why it's important that it's not just physicians that take care of women, but we need multidisciplinary folks with expertise in all sorts of things. And then I'll also add that in terms of the workforce, we need more women taking care of women. I did a lot of work in healthcare disparities in my previous roles, and I'm a Latina woman. My first language is Spanish, and there's nothing I like more than seeing a Latina woman in my practice. And women, no offense to men, we also want men around, but we do want concordance sometimes because we need that trust. And access is not just making an appointment to a provider, but access is feeling that healthcare system is invested in you and gives you the confidence like we saw in the film. I have to say, this is my third academic home, and I'm so proud to be in this room with the panelists, and an organization that provides for the community and that is willing to stick their necks out to be innovative, because that's what it takes to really change New Jersey and the communities we serve, especially around women.
Well, continuing on this topic of access, Dr. Wang, when we look at women's health as a continuum of care, primary care providers really do play such a critical, if not underutilized role. So how can they advocate and support women to have greater access in comprehensive health care, preventive, mental health, reproductive health?
Yeah, so primary care, which we all know is so important and really we should be the center of a medical home, a medical neighborhood, really is underutilized. I think nowadays in this day and age, we all want convenience, we want something fast, we go to urgent care, we go to telehealth, we don't care who we can see because I can get them on my phone right away, right? But what you lose out on is that relationship with somebody who knows you well and knows you through your life stages. And I'm an internist. I run the Center for Asian Health. We do a lot of work doing outreach to the Asian community. And like you say, Johnny, like that affinity, like that trust, like I see that people who come to us, will say, I work on Wall Street, my English is fine, but like I really feel at home when I can talk to you in, like, we call it broken Chinglish, like half Chinese, half English. You do the same in Spanish probably, right? And like you understand my background, you understand like the things I grew up with and the, Eastern philosophy of medicine, and just that we all have that little niche that we fill, where people like us kind of gravitate towards us. But I just finished seeing patients in race down here, and just today, like just the patients I saw, I started off with a college student that I started off when she was in high school. She started coming to see me. She graduated college. She's getting her first job now. She came in because she's had concussions, and I fit her in early. She called me yesterday and said, I'm having problems. I was like, I can't keep texting you, just come in. And so, it's just nice. I'm seeing her get a job now. She's moving to DC. And she was really sweet. She actually brought me 2 bracelets that I said I would wear today, and it says fearless in strength. And I was like, this is the girl I saw as a high school student, now coming to me. She has a job, she's so proud of herself. And then I saw a grandmother from Guyana who was coming to me because of viral hepatitis she's in. She's got concerns about her liver. And then during lunch, because during lunch we do telehealth, and I saw a woman who had a 2-year-old. She was nursing on camera with me and I was like, this is so great. I have telehealth because she doesn't have to drag her baby here. We get a babysitter. I can talk to her about her lab results. And that's something we've continued with COVID, that in terms of access is key for a lot of our patients. And I'm really glad our system has supported that. And at the end of the day, I saw at least 2 couples where it was the wife that brought in the husband. I saw them together, and I'm seeing their college daughter. So when you talk about CMO, it's not just when we treat the women, we treat their whole families. And so I think my message is these relationships are really worth investing in. I know our wait times are long sometimes. It's hard to get in sometimes, but our MyChart system is phenomenal now. People can book with me online. The night they're sick, the next morning, if I have an opening, they book with me right away. But that investment in a relationship is so important because I see women go through all sorts of things like depression, divorces, marriages, babies, grandkids, and I can walk into a room like a patient I've seen for years, and right away I can tell if she's depressed or there's something off. And and we should, us as primary care, we're the quarterback, right? So I share patients with Dr. Chen. We talk to the cardiologists all the time. Breast surgery, for sure. I'm always kind of working with breast surgery, when, pre-op, what do I need to do? Are you worried about this patient's hypertension? If you don't have that, you can't get that out of just urgent care. You gotta have somebody who's, your advocate backing you up. And that takes time to invest, but it's something that's really worth investing in.
Well, I think something that everyone on this panel would agree is that women can present very differently than men when it comes to certain diseases and illnesses. And Dr. Kulkarni, cardiovascular disease is such an example of this. It can affect women at any stage of their lives. It's a leading cause of mortality in women. What are some common misperceptions, myths about women's health, about cardiac care? And do you see that as really just with the general public, but have you also witnessed that within the medical community as well?
Sure. Thank you so much. Typical misconception is heart disease, heart attack means chest pain. That is true. However, women present differently. A lot of times, it's shortness of breath, it's fatigue, symptoms that are kind of atypical and nonspecific and are easy to overlook. So I'll share, just last week I was covering hospital, and a woman came to me. Someone came to the hospital. Now this woman was hosting a party for 50 people, and she started feeling tired, short of breath. So of course, what she says, first, I have to lose these 10 pounds and I'm gonna be fine. Second, she's gonna say, I'm overworked, I'm fatigued. So she continued. She didn't think anything of that, and her husband kept on telling, you're just overworked. But guess what? She completed the party. She hosted 50 people. After that, she started cleaning. Again, feeling very tired, fatigued. Everyone is saying, you're overworked. After cleaning, so after hosting a party of 50, after cleaning, then she said, you know what, I really don't feel good. Maybe we should check it out. They used ER as an emergency room, and thank God she came in, because by that time she was in heart failure. She had a heart attack. Her heart's ejection fraction when we did an echocardiogram, was cut in 50%. It was functioning only 50%. Never, ever did she have chest pain. She was tired, she was short of breath, she had fatigue. When we did an angiogram on her, she had a 99% widowmaker lesion, which thank God we opened up. She's doing okay. She's going to need another angioplasty, which we will do later, and hopefully she recovers. However, she didn't think she had heart disease. Her husband didn't think, and they all love her, and her whole family was around her. That is why heart disease gets missed. Women typically, and this is supported by statistics, they present at least 6 hours later than men. There is delay in getting first electrocardiogram. They are more likely to be dismissed as anxiety. All of this leads to delay in diagnosis. So perception is different at individual, family, and societal level. Then presentation is different, which leads to delays in diagnosis. And as a result of that, the outcomes, means if you look at this, time to angioplasty is different. That leads to more muscle damage, and outcomes are different. So women do have worse short-term and long-term prognosis. So it's sad for me to say as a cardiologist that in the spectrum of cardiology, the only thing women do better than men is to die. And it's sad because a lot of times the first presentation is a flat line. Now think about this. Heart disease is an equal opportunity killer. Think about it doesn't distinguish. Think about Lisa Marie Presley. Think about Carrie Fisher. They just didn't know that they have these symptoms. And I'll share one statistics with you. Heart disease kills more women than all cancers combined. Heart disease kills more women than all cancers combined, but still most women think breast cancer is their biggest risk. A lifetime risk of a woman having heart disease is 1 in 3. Lifetime risk of a woman having breast cancer is 1 in 38. And I have to congratulate our oncology colleagues because that's the power of advocacy. That's the power of prevention. That's the power of community education. And we need to do better than what we are doing now.
Well, Dr. Coley, that was so wonderful.
We care about breast cancer.
We need to learn from you.
Prevention. It's always the best approach to stay healthy. Screenings. This is something you talk about all the time. 1 in 8 women will develop breast cancer in their lifetime. Right? So how many of those women, if they had been screened, there could have been a big change in their healthcare journey. So how important is this routine risk screening? And how do we have to change the way that it is conducted and people find out about it or are educated?
So starting with events like this and having these open discussions and really talking about the reality of where healthcare is today, I think is hugely important. I am shocked with 1 in 3. I think that's, we have Breast Cancer Awareness Month and we talk about 1 in 8 women, and if you're at dinner with 7 of your girlfriends, 1 of you is gonna get it, and even that feels like it's almost an attack. 1 in 3 is crazy, and so these are the events where we need to get that knowledge out. With breast cancer in particular, there were screening recommendations that were put forth by U.S. Preventative Task Force during a time when things were different, and breast cancer care has evolved so much that, for example, even when I was in my breast surgical oncology fellowship, they didn't advise me to get a textbook because by the time it's published, it's outdated. And from fellowship 10 years ago, we practice very, very differently even now. So staying up to date on all of these advances is hugely important. Having a team, we have a multidisciplinary team where we really lean on each other, because that medical oncologist that is on my speed dial that I speak to more often than my husband is the one that knows the latest clinical trials that we have through CINJ to know exactly what we can get for this patient sitting in front of us. And so the things we offer are very tailored to the individual. It's no cookie cutter approach. Each cancer is different, each person is different, and we can offer something to everybody no matter what. So I think that there is sometimes a misconception that somebody is either too old to be screened or too young to be screened, and we need to hit this high yield group of people. But the truth is that I have 92-year-old patients that are diagnosed with breast cancer, and there's this thought, should I even be ordering a mammogram? My feeling is, if you can do something with that result, you should be ordering it. If it's a nursing home patient who's bedbound and has many other issues, sure, everything we do, we should be willing to act upon the result. Otherwise, it's not a useful study. But breast cancer can be treated with less aggressive approaches in that population. So we have special studies where we've studied octogenarians and people that are 90 and above. We may not necessarily operate, but we do have medications that can halt the progression and lead to regression of breast cancer. And so you can still treat a patient even if they're very old or frail, and that doesn't have to be it for them. But on the other end of it, I think that screening recommendations, when to start, this is a big kind of frustrating point that I deal with every day, is because I do see that it is happening younger and younger. I do see it in women that aren't yet of age to get screened by the traditional recommendations. And that's where risk assessment is huge. And there is a big misconception that breast cancer is hereditary and that's it. If you don't have a family history, you're safe. Only 5 to 10% of breast cancers are attributed to a genetic mutation. That means 90 to 95% are due to other risk factors that we can't test and we can't pinpoint. And so we need to be able to assess risk from all those other factors based on hormonal factors. We cannot control first period, last period. We can't control breast density. But if we at least have knowledge that some of these things are risk factors, then we can really highlight who is higher than average risk. Who do we need to do a better job in than just that screening mammogram once a year? Maybe we can use better tools that are more specific for the individual, and maybe we do need to start earlier. And you guys have given some examples. I'll give a great example of, I had a patient who was, with a family history. She went to our genetic counselor. She had genetic testing, and it was clear, 30 years old. But the genetic counselor said, you know what, you still should enroll in our high-risk program because there are other risk factors. So she was at least plugged in, had some issues that came up, didn't seem like anything major, but because we don't treat everyone the same. If somebody is high risk, we do need to be a little bit more proactive. That 30-year-old found out that she had breast cancer, and it was the day before her bridal shower. And she was then facing a cancer diagnosis through these very important, milestones. And that's when we call our colleagues and say, we need to talk about fertility preservation because she's planning her life at this moment. And we need to think of not only the years that we're working to preserve by fighting this cancer, but what are the quality of those years? Can she still plan all the things she's been envisioning with her partner? And how can we secure that future, not just longevity, but the quality of life, making sure that each one of those years is worthwhile. You can have your family, you can make sure that your medication isn't impacting your quality of life. And thinking of everything as a whole package allows you to do a much better job for that patient.
Well, let's talk about fertility treatments, because Dr. Chen, a lot of women face significant physical, emotional, financial challenges accessing fertility treatments to start or grow their families. So how can fertility specialists help them access those services, especially the underserved communities?
So I am so privileged to be here in New Jersey, and I think all of us are privileged to be here in New Jersey, and especially in the RWJBH system. We're in a very special place, but this really should be the norm. So in New Jersey follows, because we just helped pass a law that was just signed this year and takes place, just implemented August 1st, that provides for coverage for New Jerseyans under the law that according to the definition of the current definition of infertility, which is anybody who has any obstacle to conceiving and could benefit from fertility treatment. So we've removed the discriminations against single people and LGBTQ. There's no discrimination left now. And New Jersey is one of the first states to enact that, which is amazing. Now, the RWJBH system is very interesting because we're so large. I think we're one of the largest employers in the state. We self-insure. But Barnabas has been ahead of the curve for years. Barnabas provides the type of access to fertility care that everyone deserves. People forget. People are talking a lot in the news about, oh, free IVF for all, and everybody's saying, wow, that's like winning the lottery. That is not like winning the lottery. IVF is healthcare. Okay? Infertility, struggling with infertility is a devastating condition that can change somebody's life. And last time I looked, we need reproduction for continuation of the human race. So it seems kind of important, right? So, and last time I looked, we're all paying these huge premiums for healthcare, and you look at commercial insurance across this country, and 80% of good insurance, people with good insurance who are paying high premiums, getting big chunks out of their paycheck, 80% do not provide adequate coverage for infertility services. Barnabas does. Barnabas has done this for years. We're very, very proud of this program. It covers infertility the way it should, but it's not like, it shouldn't be an extra. We have to change our mindset. The norm should be to cover this disease. This disease affects at least 1 in 5 people. That is almost 10 million people in the United States. We are the only developed nation in the world that does not provide routine coverage for such a devastating condition. Imagine not being able to have a family. That's huge. So we're very, very lucky here in New Jersey because we have this mandate, largest employer in the state, providing incredible coverage. And I am so privileged to be able to see, I do see people from all walks of life coming in for these services. We still have probably 30 to 50% of our patients still not having adequate coverage because not everybody is covered under the law and not everybody works for Barnabas. Believe me, when I see nurses from other systems, I'm like, hey, you should take a look at the job board here, okay? Because they need you and you could also benefit. So, but this also brings up something you talked about earlier about like the future of healthcare and the workforce, because one thing we're very proud to do that we're still working on is providing fertility preservation coverage, not just for cancer patients. And I'm so excited because Suzanne and I have been talking about the new cancer center, like making fertility preservation a really integrated part of the system, but providing fertility preservation for our residents, for our trainees. Our female physicians have a 1 in 4 chance of struggling with infertility, and we really should take care of our own. And we've been doing that for years, trying to provide discounts, get free drugs, things like that. But we're working on trying to make that more systemic. And hopefully we will see that soon, because that's one thing I think that will help maybe address the physician shortage, because we are seeing so much burnout. We should support them because they're working so hard through their family building years. We should support their health and their wellness, including their reproductive health. So I'm probably talking too much, but.
I so enjoyed speaking to all of you before the panel to just discuss topics that you all wanted to talk about. And there was one topic that everyone brought up on this panel that is just very significant, and that is the problem in this country with research gaps in women's health. Where do you see the most significant gaps in women's health research?
Can I just start, actually, if that's okay?
Darn it, you beat me to it.
You could go if you want, but I already started, so. I told you I'd be funny. So we just talked about this the other night. We had a women's and children's event at my house, and there is no place at the NIH for women's health. There's no institute for women's health. Women's health, IVF, REI, fibroids, endometriosis, PCOS, OB, all of obstetrics, preterm birth, preeclampsia, all of those things, their home for research is the National Institutes of Child Health and Human Development. It's not women's, it's not even obstetrics. There's not a specific home for women's health research. And that is a problem. Women's health research has not been prioritized in the United States. It's a barrier for funding. It's a barrier for advancing our understanding of women's health conditions, both reproductive and otherwise, and is something, just listening to this panel talk, I was sort of itching to say, because it is something from an advocacy perspective we need to focus on. There is work happening at the federal level, so there's hope, but we have a lot of work to do.
Thank you for saying that. I think it's so true. And when I think of women across the lifespan, and I think of the conditions that they have that we don't have enough knowledge about. Osteoporosis comes to mind, dementia. Older women have chronic diseases.
Menopause.
Menopause, thank you. Thank you. Some of us have, we know that personally. It's extremely frustrating for providers, for physicians, for clinicians to see women, and women ask you for help for the most common conditions, and we are very limited. One different way of looking at these conditions, the way I see it, is really from a health equity perspective. Mm-hmm. We need to advocate for the disparities that we see, the gender gap that we see today among women. And it's okay for us to say that. It's okay, Dr. Kulkarni, to speak with your passion about what is true. I think as women, we don't have that sometimes voice. But thinking about it in a way, what do women need so that they can have the same outcomes as other populations in our society? And I think that's exactly what you're talking about as well.
I agree with you 100%. I think for decades, research in women's health was done with the bikini approach. We only focus on breasts and reproductive organs. Yeah. I think it's time to get out of that mindset and treat women as the whole person, and because we all know that guidelines in clinical medicines are made based on clinical research, and if only men are studied for clinical trials, which has happened traditionally for years, decades, that gets translated on only men's disease is studied, or any disease is studied only from men's perspective. That's what gets translated into guidelines. That's what gets taught in medical school. That's what gets practiced, leading to a significant gender gap, and also a gap which is, in my opinion, unacceptable gap in medical knowledge. And I think we need to change that. We need to promote more and more women to participate in clinical trials. I'm working with Dr. Sengupta to promote that. And we need definitely more women in cardiology research. I'll just quote one study quickly, because traditionally it's heart disease, chest pain, chest discomfort. And sometimes women come and we say, oh, we do an angiogram, and we say, oh, you'll find there is a pat on the back. It was just anxiety, it was not heart. When we did the ischemia evaluation in women, WISE study, we realized that women pattern of heart disease is very different. Men present with obstructive pattern, discrete lesion, blocks, we put stent, we're good. Women have a very microvascular pattern, and because of that, they have some unique conditions called microvascular angina, myocardial infarction without obstructive coronary artery disease, ischemia without obstructive coronary artery disease. Women also, now we know that women have broken heart syndrome, or Takotsuba's cardiomyopathy, which is very unique to women. Unless you study them, we won't know them. Spontaneous coronary artery dissection, very common in women. So I think these are unique perspectives, and we won't get insight into them unless more and more women are enrolled in that. And that leads to gender gap and knowledge gap.
I think, with the clinical trial gap, it makes you realize why these things are like in the blind spots for clinicians, right? Because we haven't been trained in these areas. And when we talk about menopause, I think there's now an awareness in the general population that we're doing an awful job. Like, the primary care doesn't want to take care of them. Go see your GYN. The GYN's like, go see a specialist, right? And these poor women are suffering, having hot flashes, and everybody's like, don't do hormone therapy, right? And it's an area where, like, I would like to know more about, right? But at this stage, like, I need some training. So when we're talking innovative opportunities here, such an awesome system, like, maybe this is something we should be training our current physicians. Let's, create areas and hubs of, like, women's care where, like, people can go for, like, where there's a gap. Like, there are private companies starting up with this, but I think it's like something we could do.
Suzanne,
Yes.
you're going to help us with this, right? Yeah. Okay.
Add it to the list.
Okay.
Yes. Well, and I think a lot of it is.
But we could do like a menopause training for, we're physicians. We already know a lot. We just need a little extra knowledge to be able to provide some care. Let's do it. Let's do it. Okay.
I would love that.
This group can do it, I think.
I have to agree with you that the way we're trained is sometimes very, very along a certain pathway. And surgeons don't learn women's health until you're in your breast fellowship. And then it's all women all the time, and they might be having postmenopausal symptoms from their medications that they're given, and at a loss.
Yes.
And it's okay
Everybody's at a loss.
to accept that there is a gap if you've started in a certain subspecialty, that you do need to either lean on each other, or you do need to create a program where we can look at the patient more holistically, regardless of where that training started, whether it was medicine, surgery. That should be the future of women's health, really.
Just because we don't know about postmenopausal hormone replacement therapy, I get asked cardiac clearance for HRT. Yes, because we just don't know enough.
Everybody's so nervous, yes, because there's a lack of data. And again, I did want to bring up the research thing, because in my world of IVF, as you know, it's been in the news a lot, so I've been learning a lot about advocacy lately and healthcare policy. And I do think everyone in this room, you guys are obviously invested stakeholders in healthcare. And it's so wonderful that all of you are here. We all have a voice, and we can speak up I have been at legislative days and advocacy days for things like polycystic ovarian syndrome and infertility. We do need to talk to our legislators and say women's health is underfunded because Congress does vote on allocations. And right now, the allocation for women's health, I saw a statistic somewhere, less than 5%. But I think if people hear from their constituents, if they hear from the system, if they hear from Rutgers Health Sciences, I think we have a powerful voice. We can say, this is a priority. It's half the population with less than 1% of the funding and so little knowledge. I had a patient today, she has full of polyps, young, healthy lady, regular cycles. What is her risk factor? Maybe it's microplastics or environmental toxins, I don't know. I said, we're never going to have the answer to this. I took them out. You look great today, and let's put that embryo in. But there's not enough data. There's no research. I can't answer your question, and I say that to almost every patient question. It's crazy, but we can do something about that. We have seen that speaking up to your legislators, you can get more funding. So I would encourage everybody to join a lot of these advocacy organizations. You don't have to reinvent the wheel, but you guys have, the people in this room, you have more knowledge than your average bear about healthcare, and I think your voice is very powerful.
I just want to say, I think some of the issue with women's health is like a lot of people aren't telling their stories, right? We feel shame about some of these conditions, and I think that makes it invisible too. So I really want to commend our celebration of patient stories, the patients who talked about eating disorders. Like, I just think that's so brave and it's so important. And I have so many women and girls who are facing that. And also as a primary care doctor, I feel like I don't always know where to go, but I'm glad that there are resources in our network. Right? But the more we can bring these issues out to light, then people realize that they are issues, right? They have to come out to light first.
I think that's so true. We've worked on so many initiatives together, and I would not be true to myself if I didn't also bring up the fact that there are many women who need a lot of help in the community. I came to RWJBarnabas to work in Newark, and where really a piece of my heart is, as well as in the VA. And I just saw the neighborhoods that are struggling. And women are struggling in those neighborhoods. And for me, I always think, if you want healthy communities, if you want people to walk, build sidewalks. If you want people to eat healthy foods, have healthy foods available in the community. And so I think it's very important for all of us to also think, of course, the conditions and the expertise in this panel, but the in-between spaces that women are filling, getting food for their families, and not being able to provide, not being able to take a bus. This is New Jersey. It's hard if you don't have a car to get to your doctor's appointment. If you're a caregiver, how do you leave your elder mother alone and then pick up your kids and go to your appointment? If you're pregnant, how do you manage all those things? And it just impacts so many aspects of women's health, and we see that in maternal morbidity and mortality, and in the disparities we see among African American women. And so I think that just acknowledging that is also part of women's health, the social determinants of health, is very important and something that we need to address.
You brought up community outreach because RWJBarnabas is really known as the gold standard statewide on community outreach. What is the system doing so well? What is it getting right with connecting with the community, getting more access to care for the community, and what more needs to be done, do you think?
Well, I think about Sue and her program. She's always calling me like, can you come to this fair? Can you, but she is out in the community all the time, and I can see it, how people come to these health fairs, and there is a reluctance to access, formal medical care. But when they can connect with the doctors and the healthcare providers in an informal setting, like at a church or at a festival, that makes a huge difference.
Yeah, I mean, I think we all realize we can't just sit here waiting for the patients to come to us. We got to go out there, right? People are so busy running around, like they don't even think about us unless we're kind of in their face, like at a language school or a church or mosque or something. And I think our system's doing a great job. Like somebody here was like with the community health worker. Is that you? For the region. I was like, yes, you guys are the folks that are the face of us. You're telling the community about the programs that we have. And we have all these community health workers, right, embedded in the system. They're in the emergency rooms. They're helping people with social determinants of health. So I feel like we're permeating the state in many ways.
And it is wonderful to see like focus on specific groups, because I do think people feel like I'm different. I'm not like everybody else. Like the LGBTQ program, you know, all of those like special programs to deal with people who maybe feel sidelined by the rest of society, like our Black community, our Asian community. You know, we do have to reach out and recognize that they may not feel comfortable just accessing the system in the routine way.
And as you said, we can't wait for patients to come to us. We need to go out in the communities. And communities, we have to take help of religious organization, other community organization, wherever people are, we need to go there. Because as I mentioned in my first example, this woman was surrounded by people who loved her. She was hosting 50 people who loved her, but none of them thought, because they just did not know. So that community education is needed. Risk of diabetes is very prevalent. In New Jersey, in US, it's growing. Risk of heart disease for a diabetic woman is 3 to 5 times higher than a non-diabetic woman. So when we are screening, if we tell people that, hey, you're a diabetic woman, are you screened for heart disease? You're a postmenopausal woman, your risk is going to go up for heart disease. Are you being screened? Also, we need to engage social media, because we need to go where people are, and people are on social media.
We were just talking about social media out before this event, and I think that is a big gap that we have to work on, because more people are going to TikTok for their health advice than they are anywhere else today. And we used to cringe at Dr. Google, and I would so prefer Dr. Google at this point. At least you're going to some legitimate website. So I think that's somewhere we need to focus. We're, as physicians, very busy during the day taking care of our patients. And we need to also have some motivation to go out there and share legitimate information from experts like the women on this panel, so that it is easy for this younger generation to be able to access information in a way that they feel comfortable. And just to address what you had asked, what we're doing correct, as Indu mentioned, charity care. I mean, we take care of so many charity care patients, and we really don't know the difference between a paying, a non-paying patient, because they all receive a great high level of care. Our programs like the Russian medical program, our Chinese medical program, you're taking patients that are coming in with the most barriers to care, language barriers, and they are almost like concierge medicine patients, where they're coming in with somebody accompanying them and translating in not just medical, but also a culturally appropriate way, setting up each appointment and making sure they're leaving that office with the next connection already made and following up with results. It's an unbelievable program that has been built, and it's exciting to see how that's continuing to develop in other populations as well.
I want to say, what can we do, actually, right? So I think that was the other part of your question, and agree with all of the comments that have been made. I think the system's doing a tremendous job engaging with the communities. And Suzanne and I were talking about this earlier today. There was a report published recently that basically demonstrated that Black women were 25% more likely to receive an unscheduled cesarean section. There's no biologic reason why a Black woman should be more likely to have a C-section than a white woman. There's no reason. And that data is really important. And actually, to Suzanne's credit, she's looking at those data elements in women's health across the system in a way that allows us to understand where we have opportunity. It doesn't feel good to look at data like that, but it's imperative that we do it because that's how we get better. That's how we get better. When we understand what's happening and we start to put things in place to correct it. And during my time at UCSF, we had this exact scenario, higher C-section rates in Black women. We started showing the data every month, and we started to see that difference melt away. By showing the data, we can have an impact. So I think across the system, that's an imperative, that we look at our data carefully.
Well, we are so lucky tonight because we have a lot of colleagues from other departments here. And I think it's a wonderful opportunity to talk about how other departments can help you provide better, more comprehensive women's health care. How can departments collaborate better? How, you talking about cardiovascular risk. Well, women are going to get screened for breast cancer. Can that then be discussed during those screenings? How can we better collaborate so that women get better care?
Oh, that is my dream. I would like cardiac screening for every woman, cardiac screening for every diabetic woman, just like mammography screening, because your risk of cardiovascular disease is higher. Get screened, and I think that's the level we need to elevate ourselves. And I would share some good news, some sneak peek, that we are working for the last 2 years to create a comprehensive heart center for women in the system. We have worked very closely so that we take care of women throughout their spectrum, their heart health throughout the spectrum, not like patches. Oh, you had postpartum hypertension, we'll take care of you for that period of time. Oh, you need hormone replacement therapy, we'll just take care of that. No, screening and throughout all their cardiovascular needs. We are very close, and my appeal, there are some very influential people in this room. We are very close. We would like your help to take it across the finish line. And then we will have another celebration here.
I think that this goes to, I think what you were talking about in terms of maternal health and African American health disparities. When other departments are creating programs, think of your programs from a women's perspective. When you're designing your programs, think, how does this fit women's needs? I think that all of us have to learn how to put ourselves in the patient's shoes. And not until we do that can we really spark ideas and innovation. I forget who I was talking to about a patient, but I always tell the story that one of my patients who was diabetic, and I saw her all the time, and I thought I was doing a great job. And I walked out of the clinic one day exhausted, and there was a pizzeria next to the clinic. And when I walked by, I'm going to call her Rosa, I just peeked in the pizzeria because it was the glass, a glass wall, and there I saw Rosa having pizza and soda and French fries. And
Rosa is going to see me soon.
Yes. And I've known Rosa since I was an intern and a student. And at this time I was a fancy attending. But what I realized at that moment was I didn't understand Rosa's perspective. She cared about picking up her grandkid, which is who she was having her snack with, after school, picking her up and sharing a meal with her grandchild. And so I think that's how we come together and figure things out. I learned that I was not seeing things from her perspective and I needed a shift. So from that moment on, I told Rosa, bring your granddaughter to the visit, and we can talk together about the best choices for a snack after you pick her up from school. So I think that's what I would ask our colleagues, that if they can put themselves in the in the shoes of women, and when you design a program, have women in mind.
Well, this has been a tremendous night, and really, I could stay here for hours. I feel like we just skimmed the surface on all of these really important topics, and I just want to thank you so much for taking the time out, and thanking everyone here tonight for coming to learn more about what RWJBarnabas is doing for women's health and how we can do even more in the future. So I'm going to hand this over to Suzanne.
How do you follow that? I don't even know what to say. I want to thank everyone for being here tonight. My deepest gratitude to all of our panelists for sharing their insight, their experience, their patient stories. The patient stories are what is so powerful. That's what really brings it home for everybody. We covered a very broad range of topics, from reproductive health to the impacts of social determinants on health outcomes. We highlighted not only the challenges that women face, but also the incredible resilience, and you saw it in the videos, and strength within our communities. It's clear that we've made some significant strides in women's health within our healthcare system, but the work's not done. We've still got a long way to go. As we conclude, I would encourage all of you to take the information from tonight's discussion and continue to foster these conversations after tonight. Share what you've learned, challenge the status quo, advocate for the changes that we all want to see in women's health. That's what's so important. But before we conclude, I want to recognize and thank Caitlin Olson and her team. They have worked tirelessly behind the scenes to put all of this together tonight. Everyone to join us, back out in the lobby for a bite to eat and some more networking. Thank you.
Sorry.